Shalom and welcome to The Straw Hat, hosted by Rabbi David Wolkenfeld. We are the official podcast of Anshe Shalom B'nai Israel Congregation, an Orthodox synagogue in the Lakeview neighborhood of Chicago, Illinois.
Welcome to the Straw Hat podcast. I am really happy that my college friend Rachel Weinerman is joining us. Rachel and I were undergrads together some years ago, and now as Dr. Rachel Weinerman, she's a physician who practices in Cleveland, and her work has implications for a lot of current medical ethics and public policy questions. So I wanted to bring her on to talk about her work and how it has implications, like as I said, for topics that we're all talking about. So, Rachel, can you please just first introduce yourself, to tell us where you are and where you live and what you do?
First of all, thank you, Rabbi Wolkenfeld, for bringing me on. David, if I can say that.
Yes.
We were definitely friends in college, and it's so nice to be back. So I am a reproductive endocrinology and infertility physician in Cleveland, Ohio. I practice at university hospitals, and I'm also the program director for the fellowship. So I also train fellows. And, what I do on a daily basis is really help people of all, different, backgrounds and stripes who want to conceive, who are also interested in fertility preservation, really, building families. So that's really what I do in my daily job.
So you can just break that down, just so the endocrinology part and that would be if it's a hormonal issue that's preventing people from being able to conceive, or that.
Yeah, correct. So I do work with all types of what we call reproductive endocrinology. So, hormonal issues that may affect reproduction. And then the infertility is specifically, any issues that may impact someone's ability to, either get pregnant or stay pregnant. And that has really broadened in past years because there's all kinds of issues that may prevent someone from getting pregnant. You may have couples, you may have a single person, you may have, LGBT couples. So there's all types of people that may not be able to reproduce. And then there's also people who have recurrent pregnancy loss, right? Who can get pregnant, but then can't stay pregnant. So my job really is helping people, who are struggling to conceive, get pregnant and stay pregnant with all the different methods that are available today.
So how many, you must know the babies that are born, who are now walking about on this earth because of your interventions. Do you keep a tab of how many babies you've helped bring to the world?
No, that's a good question. I don't keep a tab, but I do have a drawer. So every REI doctor has a drawer of all the cards that we've received, all the baby cards that we get in the emails that we do print out. And, it's one of those things if we're dealing with something, sometimes we have really challenging cases or hard days, you just pull out that drawer and you look at all the pictures. And that just makes you realize, all the good work that you've done in the world. And, that always makes me happy.
That sounds really spectacular and a very rewarding and important work that you're doing. So I think some years ago, your pre-COVID, your home was like a stopping place for us on our annual drives across country back to New York, and I think that's probably where we were talking about how the kind of shifting political landscape had some implications for your work. I guess this was maybe a few years ago, so some earlier stage of Supreme Court ruminations about abortion access being threatened, and you shared that you thought it was your own work in IVF and fertility treatment more broadly was implicated, which is something that I think is a little bit counterintuitive. Right, abortion is about ending pregnancies. Your work is creating pregnancies, and yet you shared ways in which your work is predicated on abortion access. So it's in the news again, actually, as we speak. We're recording this on Wednesday morning, June 8th. I think the Supreme Court is supposed to issue some decision today in the coming hours, so no one knows what it is, but it's expected that the Supreme Court will severely limit or eliminate the Roe v. Wade precedent. And so please share how this raises concerns for the work that you do.
Yeah, so I think that's a really good point, and it is true. We did discuss this several years ago, and it is now definitely back in the news. And it's actually something that I'm getting asked about daily in my practice, both from people who know me more broadly and from my patients. Because, in essence, helping people get pregnant, is really predicated on reproductive freedom and reproductive choice. And that necessitates a degree of flexibility in the law, that if that freedom is taken away, it really limits our ability to help patients who want to get pregnant, in terms of making decisions about how we do that. And I can go into more detail,
Yeah,
but
could you
that's
please?
the
That
broad
sounds a little bit
concept.
abstract. Yeah.
Yeah. So let me give you some examples, because I think that is really important to understand. I'll put it to you this way: pregnancy is complicated. Right? So when we talk about pregnancy, a lot of times people are like, oh, you get pregnant and then everything goes well. So in my line of work, that's often not the case.
Uh-huh.
So when you get pregnant, that's really just the start. And
Mhm.
then whether that pregnancy is going to be successful really takes a lot of thinking, effort, and work. And to understand whether that pregnancy is going to be, say, a miscarriage or an ectopic pregnancy that is actually going to be life threatening or dangerous to the woman because it's not implanted in the correct place in the uterus, or whether it's going to be successful, that takes some time to understand. And when there's a law that says you can't terminate a pregnancy, say, ever, or after 6 weeks, well, I might need to in order to help that patient move on to the next pregnancy if this is not going to be a successful pregnancy. But I might need time to make that decision. I might need to, make some assessments. I might not be able to know for sure what's happening with this pregnancy to say viable, not viable. And the law doesn't really give me that flexibility, right? The law is very black and white, and pregnancies are not black and white. So I would say one example is that viability is not always clear. And, for a woman who's struggling with infertility, if she doesn't want to damage her future fertility, I might need to make an assessment and say, you know what, let's intervene now before your fallopian tube is damaged, before your uterus is damaged. It's better for us to just, end this pregnancy now when we think it's not going to be viable so we can move on to healthy pregnancy. The law might not give me that flexibility if it's written in a very blunt fashion. So
And
that's
currently,
one.
these are decisions and conversations you have with your patients, and routinely.
Yeah,
And
so I'd say currently, my ability to make these decisions is really based on medical judgment, lots of counseling with the patient, and multiple assessments that really get to the heart of how is this pregnancy progressing, and then what are the patient's goals. So it's a shared decision making between doctor and patient in terms of how are we going to make a decision that best takes into account your current needs and your future needs. So that's one example. I would say the viability of a pregnancy is not always known, particularly in situations of what we call pregnancies of unknown locations or ectopic pregnancies. And I think that's a really important area where I think if the law is very blunt in saying you can't terminate a pregnancy after a certain time period or ever, that's going to really curtail doctors' ability to help women early in their pregnancies.
ectopic pregnancy is that I'm surprising. I thought it would be relatively easy to figure out that was happening with a little ultrasound. You see it's in the wrong place, but it's not so
It's
clear.
so challenging. It's one of the most challenging situations that as IVF doctors we face. We actually have a whole category. It's called pregnancy of unknown location,
Huh.
which is
Okay.
very frustrating for a patient, if you can imagine, to have a pregnancy you don't know where it is.
And a pregnancy that you've already invested so much time and energy and money in bringing to this stage, and you don't even know if it could be life threatening or it could be fine.
Correct. Yeah.
So to have to figure that out under the time, like a ticking clock of a log, would be very challenging.
Correct. Let me give you another
Please.
example. So, a lot of times my patients who are trying to get pregnant are high risk, for any number of reasons. They may be older. They may have more medical complications just to start, right? They may have diabetes, high blood pressure, things that affect their kidneys. And that's maybe why they have infertility, right? Why they're coming to see me. And that's okay, right? I am helping them get pregnant. We're going to be having them under the care of specialists. And I really want them to reproduce. They want to have a baby, they want to have children. But that also means that they may have more complications that arise in their pregnancies. And we really need to help them in those situations. Those pregnancies may have a higher rate of fetal or congenital anomalies. And sometimes patients want to be able to terminate those pregnancies either for maternal or fetal indications. They may do a test early in the pregnancy that reveals a genetic abnormality. That's more common as women get older. They may find a congenital abnormality, like a severe birth defect. That is more common in women who have certain medical conditions like diabetes.
Mhm.
And for maternal indications, they may have situations where their kidneys are failing and they need to terminate a pregnancy for their health. Severe blood pressure may be threatening to the mom. When does health conditions become life-threatening? Or I should say, when do health conditions become life-threatening? That's really a very murky line. And a lot of these laws are being written to say there are exceptions for maternal life. Now, to the layperson, that may sound great. Okay, you're going to make exceptions for maternal life. But to a physician, I don't know when maternal health turns into maternal life. When does something become life-threatening? I can say, well, if this pregnancy continues for 3 more weeks, then the mom's, health might be at risk. But if I terminate it now, then she's more likely to be able to go on to have a healthy pregnancy. So is that a life-threatening complication, or is that just, going to make it easier for her to have another pregnancy? So these are really very, very challenging situations. And physicians really don't want to be in the situation where they're challenging a law because, if they end up terminating a pregnancy against the law, then their license may be at risk, or, they actually may face criminal charges or jail time. So, when I'm making decisions that, involve a patient's health, I don't want to have to be calling a lawyer every time, I'm trying to help a woman make a decision. And so when I'm thinking about a patient situation, I really need some flexibility in terms of, her health, her future fertility, and what's in her best interest that a lot of these laws don't provide.
Wow. Yeah, it's interesting. Just thinking about some of the halachic cases of where we violate Shabbat for pikuach nefesh, where my understanding from what I've learned is we have a very, very expansive sense of what could be pikuach nefesh. Even fairly remote risks are often included under that rubric. I know of a case of a young woman who she fell and gashed open her face on a Shabbos afternoon, and a ambulance corps was called, because an open bloody wound is something that needs to be treated, and that seems pretty obviously pikuach nefesh. A big untreated wound on your face is not something you can wait to treat. But the closer hospital was a lower quality hospital, and they would patch her up and they would make sure that the wound didn't get infected, but it would leave a very disfiguring scar across her face. And if they continued to drive her an additional distance, they could take her to a better hospital where they would have do better suturing, and she wouldn't have a disfiguring gash. And the postdoc who discussed this case with me said that he told it was a Jewish ambulance corps, said drive the extra distance, take her to a better hospital. She should not have to go through the rest of her life with a disfiguring gash across her face. And once we're treating her, we treat her in that best possible way. We care about her future well-being, and incorporate that into this pikuach nefesh framework. It seems like it seems like you're also making kind of weighing these sort of multiple factors. It's not just will this person die today if I don't intervene. It's like what is the scope of this person's future, given these weighty risks to her, and so.
Yeah, it's challenging. I mean, a lot of times, let's say the couple, does have, unfortunately, a pregnancy that's affected by a major congenital or fetal anomaly. Typically they're offered 2 choices. They can terminate the pregnancy, or they can carry the pregnancy to term. Many times that pregnancy is not going to survive, more than, say, a few days after birth, or maybe even a few months. So in that situation, let's say the woman decides to carry the pregnancy to term and deliver, and then let's say the baby only survives for a couple of days. So in that situation, we're looking at it now from her fertility perspective, right? She wants to have a healthy child. Carrying that pregnancy to term may actually sacrifice her ability to have another healthy child, because she may have damage from carrying that, that pregnancy to term. She may have to have a C-section, for example, that may limit her ability to have another delivery. And the time that she spent carrying that pregnancy and recovering may sacrifice her ability to conceive another healthy pregnancy depending on her age.
It's really a different kind of moral calculation than a younger couple who has much more time to play around with and is able to conceive without medical intervention. It's just a different moral calculation, I think, or right than somebody in this situation. That sounds really quite significant. What about issues of I guess you have frozen embryos in your clinic's freezer, I guess, right? Is that how does that play into these discussions?
Yeah, I think that's a very interesting question. It kind of gets to the more fundamental issue is, what is the fundamental issue of IVF? What is in vitro fertilization, which is one of our big fertility treatments? So that involves actually taking eggs from a woman's body. So we usually give hormonal treatment, stimulation to grow the eggs. We take them out of a woman's body and then we fertilize them in a petri dish with sperm. So that creates embryos in a petri dish. And then we usually create multiple embryos because it takes a lot of embryos to find the best one. And then we transfer that embryo into a uterus to create a healthy pregnancy. Now, if we're very lucky, it will work on the first try. Often it doesn't. But we do sometimes have extra embryos that end up, being frozen for future use. So that gets to the question of what is the status of those frozen embryos, in the law. And currently, there's no special status of a frozen embryo. So they can be discarded or used for training purposes if the couple want. Now, it's interesting, federally, you can't do research on embryos with money from the federal government. Like there's a limitation on that. But there's nothing to stop a fertility clinic, say, from doing training or research on embryos from, with private funding.
Mm-hmm.
But, laws that define a conception, meaning a egg and a sperm that's fertilized as a person in the eyes of the law, would seriously curtail our ability to, discard frozen embryos. And that really would then limit our ability to do in vitro fertilization because we wouldn't be able to have excess embryos either frozen or discarded.
Just to play this out, it's not feasible for a couple who wants to do IVF to just harvest one egg or fertilize one egg and implant that egg one at a time because it's so often it takes multiple attempts, and to go through that process of harvesting the eggs each time isn't plausible. And to just store them in perpetuity is I guess an expense that is also not. I mean, I know people who've stored eggs for years, and every time they have another child, every several years, it's the same batch of frozen embryos that they use for each child that they've given, that they've had. But I guess eventually, often they run out of, they're done. Their family is the size that they want it to be, and they're extra frozen embryos, and those are typically discarded. That's routine.
Yeah, so typically those are either discarded, donated to other couples, or, like I said, used for research purposes. So, embryo donation is an option for couples, but not everybody wants to donate their embryos to somebody else for use. So a lot of them are discarded. But, like you said, sometimes people do want multiple children, and then they can use their embryos for multiple pregnancies, which is ideal for us. We're very happy when couples can build their whole family from one IVF cycle and have many embryos frozen. But there often are times when there are extra embryos, and there are millions of frozen embryos stored right now in the country. So, that becomes an ethical challenge or a legal challenge, if you redefine an embryo in the eyes of the law.
So I guess you don't see it as an ethical challenge because I guess can you share a bit? These embryos do have the unique DNA of the person they might grow into, right? There is a unique, never before seen, never again will be seen combination of DNA, but you don't see them as people. I guess you deal with them all the time. I've never seen one. So what's yeah.
So, I mean, I'm a doctor, so I'm looking at it from a medical perspective. We can also discuss it from a halachic perspective if you're interested. But from a medical perspective, what happens is an egg and a sperm come together in a petri dish, and then they begin to divide. If you remember from biology class, there's the process of mitosis. Most people probably dreaded learning about that in biology. But it's where cells divide. So you go from like 1 cell to 2 cells to 4 cells to 8 cells. So dividing exponentially. So we actually keep the embryos in the petri dish for 5 days. So when we're talking about embryos, it's a fertilized egg that has grown in a petri dish for 5 days. So by that point, it's gotten to be about 100 cells. And it's differentiated into 2 different cell types. Okay, one cell type is actually going to hopefully grow into the fetus. And then one cell type is going to grow into the placenta, which is the organ that actually provides the nourishment for the fetus in the uterus. So it's really about 100 cells. It's shaped like a sphere. So it's a cluster of cells. In my mind, it has the potential to become a fetus or an embryo, or if you want to say it has the potential to become a person. Because in order for all of those things to happen, it has to be transferred into a uterus, right? So a woman has to have a uterus. You have to transfer it into the uterus of a woman. All the environment has to be perfect. It has to implant. And then it has to grow. And when we transfer embryos, even under the best conditions, only about 60% will implant and form a healthy baby. That's like in the best case scenario. Sometimes, depending on the age of the woman, it could be as low as 15%. So I guess to me, because the potential is there, but there's so many steps that it takes, I really see it as these are a fertilized egg that in the right environment has the potential to become.
And I understand that's not all that different from natural pregnancies, that this, the way God made men and women, a substantial percentage of eggs that are fertilized don't end up as healthy pregnancies. Many of them are miscarried without the parents ever knowing that there was a pregnancy to begin with. It seems that fertilized eggs are almost a byproduct of human reproduction in really substantial numbers.
Yes, I would say we are not very efficient reproducers.
Okay. So somehow, right.
We're not rabbits, which is fine. I think that there's probably some reasons for that, but eggs, they sit in what we call meiosis, in a rest for many years, and many of them have meiotic error. So many eggs are actually chromosomally abnormal, and that's one of the reasons why a lot of embryos don't implant. And just for other reasons, many embryos don't implant. So there is potential, but it's not actualized potential in many cases.
Yeah, I just to echo, I think the halachic consensus is that embryos that are outside of a person that have never been implanted into a uterus are not considered lives, and are not. There's no general permission of breaking Shabbos, for example. You can't break Shabbos to save a frozen embryo from being destroyed. If your freezer gets unplugged, you have to plug it back in with a shinui. You have to use your elbow or something to turn it back on, or ask so you wouldn't be a heter to break Shabbos directly to save a frozen embryo. That it's has great importance to the family that wants it, and it could lead to something, but is not itself yet. So what's the state of affairs in Ohio? Do you know, like, what pending Supreme Court decisions, like what other laws on the books already in your state? Or is that something you're thinking about, or something your patients are asking about? Like, what's
Yeah, so Ohio is interesting. So we do have a Republican-controlled legislature, and currently there are 2 potential laws that are options. So there is a 6-week, what we call heartbeat bill ban that is likely to be passed if Roe v. Wade is overturned, which means that there'll be a blanket abortion ban starting at 6 weeks of pregnancy. And that is likely to be passed in Ohio. So exceptions would only really be for the life of the mother, which is, what I talked about before, that kind of murky line. So, for example, if a woman did have, a fetal anomaly diagnosed or genetic abnormality diagnosed, she would have to go out of state for care. And then that would potentially, affect my ability to care for women like in those situations, past 6 weeks of pregnancy, but, on the border of viability. But it wouldn't necessarily affect my ability to practice IVF because it would define abortion at starting at 6 weeks. The other bill that is actually currently being debated in the Ohio legislature would be a total abortion ban, meaning all pregnancies. That may not come to a floor vote, but that is what is currently was actually debated 2 weeks ago in the Ohio legislature.
So how do your patients relate to these? And yeah, how I guess they're aware also, like all of us are. What concerns do they share with you?
So, my patients are concerned. I think they are concerned mostly because, like me, they want flexibility in terms of how they, pursue their fertility treatments. They want to be able to make sure their frozen embryos are safe. And they want to be able to make choices that, best reflect their needs. So I would say a lot of my patients have asked me, is IVF still going to be legal? Am I still going to be able, to get the care that I need? And, I have to reassure them right now it is. I hope that it will be, but that's something that we will have to see. I would say one situation that I think has come up that I think is really important to address, and I have addressed with my patients, is that, as women get older, like I mentioned, there is a higher rate of genetic or chromosomal abnormalities that occur in pregnancies. And so many women will make the decision to do genetic screening early in pregnancy, which we can do, even earlier than we used to, but not earlier than, say, 11 weeks of pregnancy, sometimes by blood tests. And then they will terminate, if there is, for example, what we call trisomy extra chromosome, like trisomy 13 or trisomy 18. Some people will terminate for Down syndrome, which is trisomy 21. Some people won't. We do have the ability to screen embryos in IVF. That's something called pre-implantation genetic testing, or PGT. So people are asking me, should I do pre-implantation genetic testing, or PGT, to screen these embryos so that I'm less likely to have to terminate a pregnancy for genetic, reasons if we don't have the ability to do that in Ohio.
Why would that sounds like a win-win? Why wouldn't they want that? Is there a what's wrong with that as a solution?
So it's not necessarily wrong as a solution. The only challenge is that, PGT comes with its own issues. There's some controversy about whether, the testing may not be 100% accurate, and we may actually be discarding embryos that do have some reproductive potential. And so, for patients who are really struggling to conceive, I don't always recommend it because it doesn't necessarily improve success rates for those patients. So, patients may make decisions that may make it somewhat more challenging to get pregnant, but on the other hand, decrease their need for potential terminations, depending on the legal climate in Ohio.
Wow. So can you share a little bit about how this is percolating through your community? Because you're not just a physician, you're also a mother and member of a shul community in your neighborhood in Cleveland. Can you share how are your neighbors and friends talking about this? And I understand they're turning to you as well for guidance as these questions are back in everyone's mind.
Yeah, so it's really interesting. People have been asking me all the time, what is the Orthodox stance on abortion? And it's interesting that they've turned to me as a reproductive endocrinologist to ask those questions. At first, I was a little surprised that, people were asking me, but, I don't find that the connection between infertility and abortion is, counterintuitive. I actually think it's a continuum, right? Like we are helping people, make reproductive choices. So to me, it's natural. But I was surprised that other people made that connection. But they did, and they've been asking me, and they've come at it from two perspectives. Some people just want to know, what is your view? What's the Orthodox view? And some people are coming at it from the perspective of, oh, well, Orthodoxy doesn't believe in abortion, right? And so that's been very interesting to address. So, I've really been trying to educate people that actually Judaism's view on abortion is a lot more flexible than, say, the Catholic or, evangelical view of abortion is. And this is going to affect my ability as an infertility physician to provide care. So those are the 2 points that I've been trying to educate people so that they understand that this may affect their lives as well, no matter where they are on the political spectrum and no matter where they are in life, because they may have daughters, sisters, wives, nieces, granddaughters, that may need reproductive care. So that's kind of the general conversation. I'm happy to expand.
Yeah, please do expand, because I think I think the sort of a stereotype of who needs abortion access, it's somebody maybe not living a like a I don't know, like a pious from lifestyle, but actually like our shuls are filled with kids who were conceived with assistance from physicians like you, and so what you're sharing with us is that actually this legal issue, this political issue, is directly implicated in the way our community operates right now.
Yeah, so I think what's interesting is twofold. So I think that there is this tendency within certain aspects of the Orthodox community, I'm not saying all, but I think in some, to conflate right-wing politics with Orthodox principles. And so there is this tendency to say that, as Orthodox Jews, we have to, support conservative views on abortion, which I don't necessarily think really makes sense from a halachic perspective.
Mm-hmm.
Because from a halachic perspective, I would say we really want to maintain flexibility, since our view of abortion is really fairly flexible in the sense that, we do obviously have a very high respect for the fetus and for pregnancy. And our general guiding principle in halacha is, pru or vu. That's the guiding principle that I use in my practice of medicine and that we use in Judaism. But we also have a very high respect for the health and well-being of the mother. And we don't necessarily place the well-being of the fetus above the health of the mother, until the very end of pregnancy. And so there are many situations when termination is not necessarily even allowed, but recommended, depending on the situation. And it's very individualized. So I don't think that women or even couples should just assume that Judaism says that abortion is not allowed. I think that it's much more nuanced than that. And, there are many situations when an Orthodox woman may find herself in need of a pregnancy termination, or may find that the pregnancy care that's recommended by her doctor in a desired pregnancy is actually considered a termination under the law. And so you really want the law to be as flexible as possible so that halacha can guide, along with your medical doctors, what is the proper care in those situations.
So how do they hear this message at shul? Like when you're, schmoozing at Kiddush, or I don't know, like at the playground while your kids are playing, you're talking to other parents. Like, do people get this, or do you feel there's resistance?
I think when I phrase it that way, people pause. It's very challenging to, sway a very long-standing political belief. But I think that when you phrase it that way, people pause and they say, oh, you know what? You're right. And then they backtrack. And then they say, you know what? I've never actually believed in such an extreme abortion ban as what's being debated now. I've always held a middle ground. And I wish that we could have a middle ground, right? I don't think that we should have an extreme, abortion is available on demand for everybody all the time, but there should be some regulation, but there should be exceptions. That doctors should be allowed to make those decisions. There should be health exceptions. We shouldn't have the extremes that are being proposed now. So I think when it comes down to it, yes, they actually agree, and they don't agree with the very severe laws that are being proposed. And so, but they also don't agree with the very liberal policy. So when you come down to it, then they realize, oh, maybe I don't agree with either side.
Okay. So that's a hard place to be. Maybe that's also a very authentic Jewish position, is not to have your views necessarily reflected by a major other group of Americans right now. That's really important. Anything else that you want to add? Something I haven't asked about, or something you'd like to develop further?
Well, what's interesting in talking about what I've heard from people, I've been surprised by, in this vein of how much, what is influenced by Catholic views has permeated the general view, how much in the Orthodox community specifically, people do think that the embryo has a halachic status.
Mm-hmm.
That people are concerned by, how do we dispose of embryos, or are we allowed to dispose of embryos, or are we allowed to do IVF from the Jewish perspective? And I think that's really, in my mind, probably influenced by the Catholic view, because that's not really a Jewish concept.
Mm-hmm.
That you said the halacha does not really provide a special status to the pre-implantation embryo. And that's something that I think probably requires some education from the Orthodox community so they can understand that nuance.
Yeah, right. I mean, I think the people who need this type of intervention, they probably learn it, but then the rest of the community doesn't necessarily know. I think you're right. And it's a common phenomenon. I'm sure everyone does it. We kind of join political movements, and we associate with bigger trends, cultural trends, and we sort of assimilate various parts of their worldview, even when some of those worldview components are really not consistent with a more authentic Jewish perspective. So this seems to be a particularly fraught example, because the people who need that flexibility are like our own members of our community. Like at our shul, little kids come and the bima for Adon Olam, and they get lollipops and they dance and they sing. And I just, I know like a substantial percentage of them were brought to the world through assisted reproductive technology. I'm sure there are others that I don't know about. And it just breaks my heart to think that these beautiful children, who are like literally the future of our community, were brought here through a process that is now at such risk. And, it seems that there's like constraints in Ohio, and I think there are other states. I've heard sort of fetal personhood laws that would go back to conception, which seems would have like really, really direct implications for IVF and, like major parts of this country where there are also Jews who live, and as well as our non-Jewish fellow citizens who have their ability to grow their families in this way really curtailed. So I think it's, I wonder if that sort of moderate regulation that seems to be a lot of the people you speak to want, if that's a possibility, or if we're going to be left with one extreme or another in the legal realm. But
I know. I wish that there was room in the debate for moderation.
mm-hmm.
I mean, I think that the polls suggest that the majority of Americans want moderation.
Yeah.
And so I do think that if we had some sort of, regulation, say in the second trimester, that left, wide discretion for physicians, I think that's something that a lot of people could get behind. But unfortunately, that's not at all where the political discourse is.
Mm-hmm. Yeah. And I guess at least in that state, I guess from my perspective, I feel like at least in a Roe v. Wade wide open abortion access kind of model, that at least preserves the ability for religious communities or other ethical traditions to promote their vision or our vision of what we think is like ethical and responsible choices, like within our own community. So no one's forced to have an immoral abortion against their wishes under the erstwhile status quo, whereas the more restrictive legislations that are being debated in various states could really take away people's ability to make very decent decisions, including about how to grow their families. So thank you very much for your time this morning. I hope we get to meet again in person under happy and healthy circumstances. And we're not driving to New York this summer. We have an Israel trip instead, so we're not going to pass through Cleveland on our way. But when we do next pass through Cleveland, we'll let you know. And you have a standing invitation to visit us in Chicago. That's I recommend during the summer, but whenever you come, we'll be really happy to see you.
Well, I hope to take you up on that soon. And I'm sure whatever the weather is in Chicago, it has to be better than what it is in Cleveland. So
really? No, is that really true?
Yes.
Oh, Cleveland's worse than I didn't know that. I thought Cleveland does seem so much more moderate and southern compared to Chicago, but it's probably not true. Okay.
No, Cleveland, we get the lake effect from Lake Erie.
Okay. So then you're used to it. So come whenever you want. Terrific. All right. Thank you so much.
Thank you so much for listening to this week's episode of The Straw Hats. This is Straw Hat producer Haley Leventhal. Apologies, we got this episode out a little later than we intended, but we hope you enjoy listening. Thank you again to Rachel Weinerman for joining us on the podcast this week. We'll be going on a bit of a hiatus this summer while Rabbi Wolkenfeld is away in Israel, so please subscribe or keep an eye on the shul website and bulletin to find out when we have new episodes coming out. Hope you all are having a wonderful and safe summer.